Good evening. It's November the 6th, 2017, Monday night. This is Respiratory 241. It's week 2, and welcome to this week's live lecture. Your instructor, Tim Dunkley. Appreciate you all joining me for this week's lecture. We have a lot to cover tonight, so I'll do my best to work through some of our housekeeping items and get into what we need to talk about for this week's quiz. Just a quick review. Good work on your discussions. I think everybody did a good job. There's always a debate and it's up for debate about what it means for the doctor to observe or not to observe and what that entails. And you could go either way, that we're just going to observe and that means the doctor's not going to do anything, or the doctor is going to observe and he's going to do everything. So that's up for debate, but as long as your angle is that we need to provide for the patient's airway and that we need to reverse her respiratory acidosis, that's what we're really looking for with this particular problem. As far as blood gas interpretation, overall, I think everybody did a really good job. It is really important as we start talking about ventilator management that everybody make sure that they are comfortable with interpreting your arterial blood gases, and that should be second nature to you as a respiratory therapist, and is of utmost importance. So having said that, we'll briefly just go over just a quick down and dirty review of that, and also just your length. Make sure that you're hitting that 150 word length for your original post, that you have that in by Wednesday, and that your posts to your fellow students are at least 50 words. As far as your assignment goes, I was happy with the assignments. I think that everybody did a good job with their assignments as well. Just remember, those need to be in APA format, and make sure that your length is appropriate for that one as well. The quiz, I was really happy. I thought everybody did overall a pretty good job on the quiz. Make sure that you review what you missed. You can see some of those questions again on the final. So if you did miss something, make sure that you understand why, and if there's anything I can do to help you, please let me know. Just to rehash last week, just make sure that you're comfortable with ventilator terminology and all the different terms that are associated with vent settings and vent values as you see it on your patient, your respiratory mechanics and the different pressures involved there, and how a breath is taken, and then your different vent types and your various modes. You're going to hear me say it a lot, but make sure that you understand the three main modes we're talking about in this introductory ventilator class that we're talking about: AC, CMV. Some of you spoke about AC or CMV as the patient is unable to initiate a breath if they want it. That's the old CMV. Now we have AC CMV, or assist control. The patient can now set their own respiratory rate if they would like above the set rate on the ventilator. So if I have a patient that's breathing on their own, let's say they're breathing 18 to 20, I'll dial in just a rate of 12 to 14 on the vent in case our sedation gets too high or they fall asleep and don't want to breathe on me, that they'll still have those breaths there. But if they want to breathe above that, they most certainly can in AC. Once they initiate that breath, the vent takes over and does the entire breath cycle for them, versus the mode of SIMV, where if it's a mandatory breath or a set breath that the machine's doing, that the patient hasn't initiated it, then that's a control breath and the ventilator does the whole breath cycle for them. The difference being in SIMV, it's synchronized intermittent mandatory ventilation is what it stands for. So keep in mind that if that patient initiates that breath, then that is a spontaneous breath type when they take that breath, and so they do the whole breath cycle on their own on a spontaneous breath. And if you don't have enough pressure support dialed in there, you can have unwanted work of breathing on that patient in that mode. That's why you won't find that mode used in a lot of centers because of that potential issue with that. And lastly, then we have spontaneous mode, and that is more of a quote-unquote weaning mode where the patient's breathing the whole breath cycle on their own, and we can dial in some pressure support to give them some help along with some PEEP or CPAP to keep their alveoli recruited. So make sure that you're comfortable that you could speak to any of those terms, and you'll do very well as we continue on in this class. As far as ABG interpretation goes, the first thing I like to do when I have a blood gas that's presented in front of me, or I'm running a blood gas, the first thing I'm going to look at is the pH. Immediately, if it's below 7.35, I can establish that it's acidic. If it's above 7.45, I can establish that it's alkalotic. I next look at the CO2. Is there any respiratory component? If the CO2 is high, then I know that there is CO2 contributing to the acidosis, or if the CO2 is low, that could be contributing to alkalosis, or are we trying to compensate? Next step is we look at the bicarb. If it's in that sweet spot of mid-20s, we know that this is acute and that we don't have a lot of compensatory mechanism in play there. And as we continue on down, we can establish at that point, now that we've looked at our CO2 and our bicarb, that we can establish, is it compensated or uncompensated? And lastly, we can look at our oxygenation. We can look at our content O2, look at our hemoglobin, see what our oximetry is telling us, and also our partial pressure, our PaO2. And with that, we can put together our content oxygenation. We can look at our AA gradient, all those different factors. As I mentioned those items, if there's something that I've mentioned that doesn't make sense to you, go ahead and shoot me a text or an email, or and mention it in the discussion or whatever you'd like. And let's make sure that you're comfortable with ABG interpretation as we continue on. It's important to, one, identify the respiratory failure, but two, to correct it on the ventilator or on the non-invasive ventilator to get that patient to return to normal values. So really important. And again, if you don't understand or if there's terms that you didn't recognize as I speak to it, make sure that you get in touch with me, and we'll make sure you're comfortable with all of those terms. And then you know, there's lots of images out there, and this is just a quick image that I pulled up, and this just gives you a quick rundown of basic ABG interpretation. As you continue on to more advanced critical care, we can start talking about gap acidosis and contraction alkalosis and anion gap and things of those natures, where you have ions, positive, negative charged ions in play when we look at the electrolytes in our chemistry of our blood. But at this point, let's stick to the basics here. And there's lots of different charts and pictures online that you can print off and keep in your pocket to refer to as whether you're in your clinicals or doing an assignment, or when you're sitting on the bus or waiting for an appointment or something. You can pull that out and review that, just to help you to acquire your numbers and make a quick interpretation of that. When you are in a critical care setting, you know, time is of the essence, especially when we have acutely ill critical patients, that the quicker we can identify the issue and start working on correcting it, all the better. And this week's discussion post talks about early identification of respiratory failure, and we'll certainly be talking about that tonight. So this week in Pill Beams, your chapters are 4, 5, and 6. And then you'll be addressing some of the things you learn in both the discussion and the assignment. And of course, all that's due by Saturday night. And you also have your quiz at the end of the week. And I hope to continue to see this nice trend of these good scores that you're all working hard and posting. And then that tells me that you're paying attention to your reading and jumping in and getting some good study in. I'm thrilled to see that. So let's jump out of this one and let's jump into our slides for tonight's talk. So we're going to talk about establishing the need for mechanical ventilation now. There's lots more into it than just looking at the results of a blood gas. That certainly plays into the K, plays into the decision that we're going to make if we're going to place someone on mechanical ventilation and provide them life support. But we also have to make some decisions. Is it going to be beneficial for them? Are they going to have an effective outcome? Is it going to actually improve their quality of life, reduce their length of stay? Is it actually going to give them a positive outcome and keep them alive? There's also things to think about of living wills. Is it the desire of the patient and or the family to be placed on mechanical ventilation? I've certainly been confronted with situations where I've had a patient stop breathing and the physician has me go ahead and intubate the patient and start breathing for them, and then we have a document provided to us, either family shows up or what have you, with documentation that they did not want that, and so we promptly take the tube out and they pass away. So that's certainly something to keep in mind before we place them on mechanical ventilation. The objectives, obviously, is that we want to support that gas exchange and reverse that respiratory failure, reduce their work of breathing, increase the lung volumes. And so we want to reverse that respiratory distress and that respiratory failure, whatever type of respiratory failure we're dealing with. Are we dealing with hypoxic respiratory failure? Are we dealing with hypercarbic respiratory failure? We might just need to protect the airway. We might need to give the heart a break and take over the work of that from them. We might have people that have they're sedated because they've come out of the operating room, and so we're protecting the airway and breathing them for them in that situation. So we talk about distress versus failure. We need to evaluate how the patient looks, the view from the door, the initial impression, and then we can start checking them out, their airway and their breathing and their cardiac history and what they're showing us currently with their circulation. So we're going to look at their respiratory rate, their heart rate, their blood pressure, what's their temperature, what's their oxygen status. And those folks in distress certainly more often than not are going to degrade into respiratory failure. When we talk about respiratory failure clinically, it's an inability to maintain PaO2 or PaCO2, which is related to pH at acceptable levels. It can be either or both that we're dealing with. If we have a PaO2 below the predicted normal range for the patient's age under ambient conditions, then we deem that patient as hypoxic respiratory failure. So where I'm at in Utah, that predicted is going to be 60 to 80. If you're sitting at sea level right now, that's going to be 80 to 100. So based on where you're at and what your elevation is, that can be dramatically different than someone else in another portion of the country. The thing to keep in mind is when you take your exam from the MBRC, that you keep in mind that the MBRC quote-unquote hospital is always going to be at sea level. So anything below 80, you need to act upon on your test. Certainly if we're talking about hypercarbic respiratory failure, a PaCO2 greater than 50 and rising is grounds for acute respiratory failure, and also a falling pH of 7.25 or lower is also a way to clinically define acute respiratory failure. So there's two types, and I mentioned this, that we have hypoxic respiratory failure. We have tissue hypoxia. It could be a VQ mismatch, diffusion defects. We can have shunting. We're just not getting enough gas to the alveoli. The patient could be aged. We're not getting in enough the required concentration of oxygen that we need. We can also have hypercapnia, where it's acute ventilatory failure. Keep in mind that the lung, if we were to stretch a lung out, an adult lung, it'll take up almost a tennis court. So the lung's really effective with all that surface area to pass oxygen into the bloodstream. So we can have great saturations and still be in hypercapnic respiratory failure because of how efficient that lung is to pass oxygen into the bloodstream. So keep in mind that we can have great SpO2 and have high CO2s because oxygenation and ventilation are related, but they're different entities that we need to deal with respiratory as respiratory therapists, if I can get that word out. So when we recognize hypoxemia, mild to moderate, they can be short of breath and breathing fast and disoriented, and lethargic. Severe, anything from breathing fast to breathing slow, cyanotic. Eventually you're going to go bradycardia, loss of consciousness, and coma and death. With hypercapnia, similar, you can be breathing fast, a high heart rate, headaches, drowsy, confusion. Oftentimes you see patients that have high CO2 levels almost act like they're inebriated. And as that CO2 continues to rise, they get really jumpy and excitable and anxious. And then eventually that high level and that pH drops and the patient starts losing consciousness and coma, which will eventually will degrade to death. So when we have successful outcomes, we give the patient supplemental oxygen. We make sure that the airway is open by either opening it ourselves or putting an adjunct airway in or breathing for that patient or putting a breathing tube in. That we monitor that either via pulse oximetry or ABGs. As far as physiologic measurements, this is really an important table, and I urge you all to memorize this table, because these numbers that we don't necessarily measure before we put someone on a ventilator, when we're getting ready to take someone off a ventilator, when we think that they're strong enough to do well off the vent, we look at a lot of these numbers, and it's important for you as a practitioner to recognize what these numbers are, so that when you walk up to that intensivist and say, hey, here's my weaning parameters, I think we're good to go, that you don't have to go and refer you to your book or your phone to make sure that we're in a good spot. So as you can see, you have your normal ranges and then your critical values. So if I'm weaning somebody, just extubated a post-op patient on Saturday, and so when I did my spontaneous breathing trial, I wanted to make sure that her vital capacity was greater than 10 to 15 cc's per kilo, that she was taking adequate tidal volumes, that her respiratory rate wasn't above 35, and that her RSBI, where we look at the respiratory rate and the tidal volume, was less than 100. So once all those looked good, then I knew I could proceed to go ahead and extubate that patient. Spoke to the physician, he was in agreement, and I pulled the tube, and she did really well. So make sure that you know your normal physiologic measurements and also your critical values, and keep in mind that you want to be above those critical values before you deem that patient safe to extubate. So as far as other measurements that we can look at our blood gas, and we had that in last week's discussion. It's the best indicator of adequate ventilation is our PaCO2, or our level of CO2. And remember, these are all pressures, so we're still talking about pressure gradients in and out as those molecules travel throughout the bloodstream. Also, we have the partial pressure of oxygen in the arteries. We can look at saturations by pulse oximeter, but keep in mind that if it's carbon monoxide or methemoglobin, that oxygen saturation might be falsely high. Also keep in mind that oxygen saturation is dependent upon circulation, that we can be satting 100%, but if our heart pump isn't working great and we're not getting that out to the tissues, even though it says that we're not hypoxic, we still may be, or that we're not hypoxemic, that we still may be hypoxic. And so I'll put in a discussion post that talks a little bit about that this week. But we certainly can look at our content oxygen that takes into account our hemoglobin, and then we can look at our PaO2 to PA big A O2, which is our AA gradient, and I can talk a little bit about that in the discussion post. And then we also have our PF ratio that I can place in a post this week. So maybe I'll kind of keep our theme of oxygenation this week in this week's post from me. So as far as treatments for hypoxemia, if we're hyperventilating, we need to breathe more and move more volume through there. If we have low VQ mismatch, or we have VQ mismatch, we can give them more PEEP to recruit that. Also, if they're shunting, if there's a diffusion defect, that could be just thickening of the alveoli. We give them steroids to get that inflammation down. If we have low barometric pressure, we have high altitude pulmonary edema or some issue like that, we're at high altitudes, we want to get those patients to lower altitudes as fast as possible. If it's an oxygen issue with low concentration oxygen, obviously we want to give them some supplementary oxygen. So criteria for invasive ventilation, that they're not breathing, that they're in ventilatory failure or impending ventilatory failure, and we have refractory, meaning that whatever we're trying isn't fixing it. So we try them on BiPAP and we still not moving enough volume, and their CO2s are still rising. That would be an issue to place them on invasive mechanical ventilation. If we are refractory hypoxemic, we've turned up their PEEP, we've turned up their oxygen, and they're still satting poorly and their PaO2 is low, then that can also be criteria for mechanical ventilation. I do want to mention a brief note about BiPAP, that if someone fails on BiPAP in this day and age, as good as our BiPAP machines are, please respect that. BiPAPs are really good these days, and I've seen patients go to comfort care off a BiPAP and have passed away within 5 to 15 minutes. And so that tells me that if someone fails on BiPAP, because BiPAP does such a good job in this day and age of supporting life, that if they're failing on that and I have to intubate them at that point, really respect how sick they are, because that BiPAP couldn't support them. So having said that, there are all alternatives. We can try oxygen, position them, try non-invasive ventilation, which we often refer to as BiPAP. If we do have indications for BiPAP, it can be that they're tachypnic, that we don't have severe respiratory failure. BiPAP works really good for cardiogenic pulmonary edema. We can turn our PEEP up, things of that nature. But if we start breathing, we're not protecting our airway, we're impaired mental status, they won't tolerate that device, and that's time to put in an invasive airway and intubate them and put them on the ventilator. So moving right along, we're going to now move on to chapter 5. And again, forgive me for moving fast here, because like I said, we have a lot to cover tonight. I want to make sure we cover everything for you, so that you're as prepared as you can be for this week's quiz. So now we've talked about briefly through those slides from chapter 4, we talk about respiratory failure and indications for a ventilator and why we'd put them on. And then wrapping up, we talked about some potential alternatives to mechanical ventilation. But now we've drawn that line in the sand. We've intubated our patient. We're going to place them on mechanical ventilation. Let's select the mode and put them on the vent. Here's a brief talk here about non-invasive positive pressure ventilation and indoor BiPAP. There's two methods to do that. The first one is just put them on CPAP, which is just PEEP. It's one pressure, and it does really a nice job for oxygenation. The problem with CPAP with that one pressure is it's just opening up and distending airways and alveoli and recruiting those so that we oxygenate better. What it's not doing is helping that patient ventilate because there's no pressure gradient there. And so when you talk about BiPAP or non-invasive ventilation, you need to dial in an upper pressure or an IPAP, and then your EPAP, of course, is your PEEP. And the greater the gap is between those two numbers, if I have a patient on 18/7, with the Philips Respironic type brand, you're dialing in a PIP and a PEEP, then that difference is how much pressure support you're given. So if we're 18/7, then we have a pressure support of 11 there. And so if we need to further blow CO2 off, then we need to turn up the IPAP or turn down the EPAP and widen that gap. And the wider that gap gets, the more opportunity for ventilation or more pressure support, which in theory gives you a bigger breath so you can blow off more CO2. If you are dealing with oxygen issues, then we need to work on using PEEP and FiO2, and so we might tend to keep that PEEP and the FiO2 higher to take care of the oxygenation issue. Sometimes when you have a combined hypoxic hypercarbic respiratory failure, we have to use a combination of more. We have to use a combination of both and use both a higher PEEP and hopefully a little higher IPAP so that we can take care of the CO2 and the oxygenation issue. So advantages, we don't have all those associated issues with artificial airways. We don't have to sedate as much. People can still talk okay and communicate. We don't have to use major sedation, that sort of thing. Though we can cause gastric distension, we can cause pressure ulcers on the face, which I've seen, mass leaks, claustrophobia, all those are issues that can arise while they're wearing that, and so those are major disadvantages. Some people can't sleep, and they just don't tolerate it, and so those are considerations as well that we need to take into account when we place someone on non-invasive ventilator. When we talk about putting someone on a vent, are we giving them full or partial ventilatory support? When we talk about full ventilatory support, that's more your AC, CMV type settings, where we set a rate and a tidal volume or a volume or a pressure, and when they trigger that vent, then the vent takes over and does all the work for them. Versus a partial ventilatory support, where the patient participates in the work of breathing, that's more your spontaneous mode or your spontaneous patient breaths on SIMV, where they participate in the work of breathing, and once they breathe that whole respiratory cycle on their own, and we're just giving them a little bit of help or augmentation to get them through that breath. So breath delivery and modes of ventilation. We have some things to think about. What type of breath are we going to give them? Is it going to be a mandatory breath, such as ACCMB? Is it going to be a spontaneous breath, like spontaneous mode, or is it assisted, where they trigger that vent, but then the vent takes over and does the whole cycle for you? Remember, we spoke a little bit about this last week. What's our targeted control? Is it volume? Do we want it to hit a preset tidal volume or a volume control? Or do we want to have it hit a preset pressure to protect that lung, and so that's a pressure control? We also have the timing of breath delivery, where is it continuous mandatory ventilation, and we have a set rate that the patient's going to get a breath based off that rate. So if we have a rate of 12, there's going to be a breath every 5 seconds, unless they trigger one on their own. Intermittent mandatory, where there's a set rate and then any other spontaneous breath above that, they do the breath cycle on their own. Or continuous spontaneous, where the patient's setting their own rate of whatever they want, and there's no quote-unquote backup rate there. So mandatory, the vent controls the timing, tidal volume, and inspiratory pressure, does everything. Versus spontaneous, the patient controls the timing, the tidal volume. And that's based on what the patient wants and how sick or stiff the lungs are versus how compliant they are. And then assisted has both characteristics. The patient generates the rate when they want a breath, but then the vent takes over and does everything throughout the whole breath cycle for that patient. So if we move on to what our target is to terminate that breath, is this is volume control. And so we set a set tidal volume. That ventilator pushes that volume in until it hits that target, and then it cycles off. The good thing about that is it tends to be, patients tend to be a little more comfortable. They have a specific volume of delivery. They get a volume of gas that we can dial in based off their ideal body weight. And it helps us predict what a certain target PaCO2 we want. The downside is that if that lung gets stiff and gets sick and worsens, then that ventilator still trying to push that set amount of tidal volume in there. We can create high pressures if that lung's stiff, and so we can cause damage to the lung. So that's something certainly we need to take into consideration. There can also be asynchrony if we don't provide enough flow or enough volume to that patient. Oftentimes they'll try and pull in more volume when the ventilator's trying to cycle off that vent. And that creates a skip or a jump in the breath and cause the ventilator to alarm. Our other way to target that is to target it with pressure. And so we set the pressure, and the ventilator pushes that volume in until it hits the set pressure, and then it cycles off. And the nice thing about that is once it hits that set pressure, then it's done. And so it doesn't allow for those high pressures that volume control can bring it in. The downside of that is if that lung is stiff, then that patient can be somewhat air hungry, because when they suck in and want a bigger breath, but it hits pressure because of their sick lung, then they don't get the volume they want, and that can be uncomfortable for them. So advantages: allows us set pressure. We don't overdistend the lung. It's a decelerating flow pattern. They can have whatever flow they want. But the disadvantages, it varies with how the lung is stiff. Then they don't get as much volume as they would like. Not everybody's familiar or uses pressure control as much as volume, I've found in my experience. And like it says there, your minute volume drops when the lung characteristics deteriorate, and set you up for potentially getting hypercarbic. So as far as timing that breath, we can have a timer patient triggered. We can have intermittent, where the patient gets set mandatory breaths, can breathe spontaneous between those, and then continuous spontaneous ventilation. So in these last few slides, we've talked about how we're going to, which mode we're going to put, what type of breath delivery we're going to talk about, and now we're talking about the timing of it. The modes can be confusing. Some manufacturers will call it VC+, others will call it PRVC, whatever they call it. And even though those two modes are called two different things by two different manufacturers, it's essentially the same deal. So don't get super hung up on exotic or fancy names. Always make sure that when you hear the name or the term, look at what your settings are and what you're trying to accomplish on that. So keep in mind that your basic modes are going to be ACCMV, they're going to be SIMV, and they're going to be spontaneous. You're through 3 major modes. The breath, the type of breath within those modes in ACCMV and SIMV is either volume targeted or pressure targeted. So we call it volume control or pressure control. And then a spontaneous, it's going to be spontaneous, where the patient's breathing on their own with a chance for some pressure support. So here we have VCCMV. The breaths are mandatory, but if the patient triggers, it's called assisted. So that's why I call it ACCMV. And they're talking about volume control here. So when we use volume control, remember you're typing in or setting a set tidal volume for that ventilator to know when to cycle that breath off. Versus pressure control, PCCMV, we're using that pressure as a target. Same with IMV or SIMV. We have VCN, pressure control IMV. Again, make sure you understand your mode, and also that you're understanding that we have a breath type within there. That if our mode's IMV, that the ventilator is going to provide the set rate there, but any spontaneous breath in between is going to be a breath that they're going to do the whole breath cycle on their own. And those mandatory breaths are going to be either volume controlled or pressure controlled. And then lastly, we have our spontaneous modes, where a spontaneous breath, the patient can breathe spontaneous through the whole breath cycle. We give them some CPAP or some PEEP to help keep that lung recruited, and then we give them some pressure support to help them take over breathing through that small ET tube so that we don't have too high of work of breathing. There are some different types of pressure support settings. There are just pressure support. There's also volume support. We can change some of the percentages of inspiratory flow and some of those breath timing and when to stop the breath or breath termination. Certainly not anything that we need to get too far into today for this class discussion. In the last several years, there's also some new modes that have come out, one of which is called APRV. Another one is PRVC, and those are new modes that have kind of married a couple of different type of modes together. They're out there. They're effective for a specific patient population. It's nothing that I'm going to discuss today. So our last chapter tonight is we've talked about respiratory failure and the types of respiratory failure, considerations before we put someone on a vent. Can we try them on BiPAP or non-invasive ventilation? Once we've done that, we need to select a mode. We need to select a breath type. And now we're going to delve a little deeper into those initial ventilator settings when we start placing that patient on there. The really common way to do this, and you'll see this on your MBRC exam, and about every ICU in the land, I'm sure, follows the same way to do that. All the literature is going to be based off of ideal body weight. So we need to estimate the patient's ideal body weight. So if we have a man and we take his height minus 60 and times it by 6 and then add 106 to it, that's going to be his ideal body weight in pounds. we want to get that kilos. We'll divide that by 2. It's roughly 2.2, but for sake of math, it's easier to do just divide that by 2 to get you where you need to be with that tidal volume. So if we have a patient and we have a patient that's 72 inches tall, and we minus that by 60, that's 12. So we take 6 times 12 is 72, and add that to 106. That gives us 178. And then if we divide that by 2, that's roughly 89 or 90 kilos. So at that point, once we have that patient's ideal body weight in kilograms, now we can start making decisions on how much tidal volume we need to give this patient. The reason we do this is because it takes into account these 2 equations, the patient's ideal body weight, aside from if they're obese or not, it takes into account their height, and it also takes into account whether they're male or female. And that's where you see the slight difference in the numbers. And so once we establish that, then we can say, okay, that we have a 90 kilo guy, and our ventilator is going to be 6 to 8 kilos, 6 to 8 cc's per kilo of tidal volume. So if we're going to go more lung protective and we're going to go more lung protective and say we're going to go 6 cc's per kilo, then that gentleman that I gave you as the example that was 72 inches high is going to receive an initial tidal volume of 540 cc's based off his ideal body weight. So that's a quick down and dirty way to do that. There's a good point there on the slide that adult lungs don't get larger as he or she gains weight. So if we have a 50 or 60 inch patient that weighs 300 pounds, those lungs, we still need to go off that patient's height, not off their total weight, because those lungs don't get larger as they gain weight, and we can potentially do harm to that patient. The other thing we need to make sure that we take into account is that we have mechanical dead space. So the tubing between the ET tube and the Y connector on the vent circuit is additional dead space. So we make sure that we are providing enough volume to overcome that in the patient. And so we start talking about now we have our tidal volume that we want to hit as our target tidal volume. How fast do we need to deliver that gas into that lung? And so in pressure control, we set it by I times or inspiratory time. In volume control, we set the flow, and it's in liters per minute. And so if we have a tidal volume of 600 cc's and we dial it in at 60 liters per minute of flow, then we're going to hit that target tidal volume. That 60 liters per minute is just how fast that gas is going to flow in to hit that target. So it's going to flow in at 60 liters per minute till it hits that target volume. And so that just accounts for that flow as how fast that gas flows in. The higher the flow, obviously the faster the gas flows in, but the trade-off is if we have super high flows, the patient might like that if they're sucking in hard, but keep in mind that if we have those high flows, that tends to cause higher peak airway pressures and can cause long lung trauma and overdistension. So we want to give enough flow or I time that the patient's comfortable, but not so fast that we cause high peak airway pressures. So here's some flow patterns that you'll see on ventilators. Most vents nowadays let you choose with a rectangular descending ramp pattern. Some of these other flow patterns were due to the way that breath was delivered, such as the sinusoidal from a rotary vane type piston. But patients tend to like the descending type flow patterns. It allows for a little better synchrony, and that mean airway pressure holds on the pressure on the lung a little longer. So most times when I'm running a vent, I'll have that vent provide that with a descending ramp type pattern. Tends to be more comfortable for the patient, allow for better oxygenation. When we have descending flow waveforms, that mean airway pressure, as I told you, that pressure stays on the lungs a little better, so that helps with oxygenation. It also keeps those peak airway pressures a little lower, and gas distribution throughout the lung tends to be a little better. So like I say, a lot of times we stick with that descending waveform. We can do a pause during volume ventilation. Most often nowadays it can be just a half a second or less, and that pause just helps us to calculate what our plateau pressure is. If the patient's not breathing spontaneous, we used to put a pause there, and what that would do is allow that pressure to pause at that upper level, and that would increase our mean airway pressure and help them to improve that distribution and allow that oxygenation to happen at that the higher pressure. If the patient's spontaneously breathing, what you can get is air trapping issues and things of that nature. So you're really on the modern vents, there's better ways to accomplish this. And the only time we like to do an inspiratory pause is when we're just intermittently checking that plateau pressure. So these initial ventilator settings, we're going to set a baseline pressure, which is our PEEP. Most centers are anywhere from 3 to 6. In my ICU, we start at 5 or 6 based on their oxygen need, and titrate up from there as needed. We are going to set if this is a pressure ventilation, we're going to dial in a pressure, an inspiratory pressure, to hit that target tidal volume. So we'll dial up that pressure up or down based on what that tidal volume is, target tidal volume is, based off of that ideal body weight that we talked about. And once we have that established, then we can start to watch our respiratory rate and so forth, and titrate that respiratory rate to our CO2s based off our blood gas. Volume support is similar. We know what our target tidal volume is, and so we want to just enter that into the ventilator, and then we can change the respiratory rate if the patient's not spontaneously breathing up or down to hit that target CO2 on our blood gas. Our FiO2 we set high and then wean down. We start our PEEP at usually 5 to 6 and then wean that down. All these are considerations before we put our patients on the ventilator. So we went pretty fast tonight, but I want you to review the lecture and pause the slides as needed, and just keep in mind that tonight we started number 1 with talking about respiratory failure, that there is hypoxic and there's hypercarbic, or ventilatory respiratory failure, that there's 2 different kinds, that a patient can present with both, or they may have one or the other. And at that point, we need to make decisions. Is it ethical to help them, or are we just prolonging the inevitable? Is it the wishes of that patient? Is it wishes of the family? What's our potential outcomes? And once we decide that, we've established that they're in respiratory failure, either with high CO2s, low PO2s, or low saturations, or a combination of both. We try that non-invasive. They don't meet criteria for that, so then we're going to place them on mechanical ventilation. We establish their ideal body weight, dial in either how big our tidal volume will be if it's volume controlled versus is it pressure controlled, but we need enough pressure there to hit that target tidal volume. We determine our mode. Is it going to be ACCMB, where if they initiate the breath, we take over and do the work for them, or we just breathe for them, or is it going to be SIMB, where it's a combination of spontaneous breaths and mandatory breaths, or are they just going to be in spontaneous mode and do the whole breath cycle on their own? So typically when we're setting these patients up, you're going to be more of an ACCMB to start out with, and then wean them to spontaneous as they get better to manage those patients. If we have our target tidal volume and we're hitting that on our patient, they're breathing on their own, then we don't have to turn that rate up or down based off what their CO2 is. But if they're sedated or they're not breathing on their own, then we need to pay a lot closer attention to what that rate needs to be to take care of that CO2. So we covered tonight a little quick just to make sure that we get through all those slides. I want you to get through all of those and see them. The beauty of the recording is you can pause and stop and look at what you need to as I talk about it. But make sure that you read your chapters and then go through and look at the lecture. If you have any questions from tonight's lecture or last week's, don't hesitate to contact me, and let's make sure that you're comfortable with where we're at with that. It's really important that you understand what we're talking about, so that as we move on to lessons in the coming 2 weeks, and also your coming upper level vent classes after this one, and ultimately your Team C exam, that you understand these basics and these concepts, so that you do have a nice understanding, and don't get confused with the next classes coming up. So appreciate your time tonight. Let me know if there's anything I do for you. Remember, everything for this week is due on Saturday night, and make sure you have that first post in by Wednesday, and let me know if there's anything I can do to help any of you. And with that, thank you and have a good night, and we'll talk to you same time, same place next week.